Yes, actually, we use this for all stages. It doesn't matter. The stage doesn't matter. I think the later stage patients frequently are very nervous. They get their surgery done immediately at their local hospital and they don't want to wait. I think as the earlier patients do a little bit more research, they tend to look for, they have a breathing room and they track us down. So we do a lot of stage one cancers actually, but we do stage twos and threes too. It's actually not the most beneficial for big tumors. Surgeons actually do a really good job, I realized, of taking out big cancers because you can feel it, you can see it, and you just take more. But it's like your situation where you have a cancer and it has a metastasis somewhere that's really small. And that's what many surgeons, especially in a lot of places in the country or the world, where it's not specialists doing these operations. When you come to a larger academic university setting, there's many more specialists who, for example, all I do is lung cancer, or I shouldn't say all, but I do a lot of lung cancer. But in a lot of centers, they don't. And so if you can improve a surgeon's decision making and their visual sight at the time of surgery, you will improve their outcomes. I think that there is a little intuition too that you pick up pretty quickly after three or four cases. And so the technology is good for any stage, any situation. I think the one situation and maybe the least impactful is not so much the stage, but the depth. So if you have an organ and it's in the middle of the organ, the
Mm.
imaging cannot see that deep into the organ. It wouldn't be able to do it because it's visual. It has to be fluorescing. Now, the flip side is if it's that deep in the organ, you're probably taking out the organ. So you didn't need it.